All right. Hi, everyone. My name is Neftali, and I work with the Communications Department here at Ripon. Thank you, everyone, for joining us for our Friday Healthy Conversation series. We have been doing this every week, Friday at noon, with a different wellness expert, healthcare provider, lots of different folks talking about how to live better managing a chronic disease. We are here today with Al Whitaker, who is the project director of the East Providence Health Equity Zone, Allegra Scharf from One Neighborhood Builders, and Robin Hall from Pawtucket Central Falls Health Equity Zone. We are recording this webinar and streaming on our Ripon YouTube page. Feel free to comment your questions in the comment section on YouTube or using the Q&A button on Zoom. Without further ado, your panel with you.
Hi, my name is Robin Hall. We are going to be talking about health equity zones. Health equity zones are an upstream approach to addressing health outcomes. I'm with the Pawtucket Central Falls Health Equity Zone. We have been connecting and supporting program partners into our 6th year now. We know that environmental factors lead to healthy outcomes are all connected. So walkability, quality housing, schools, access to care, among lots of others. But if we're going to support neighborhoods and have lasting improved health outcomes, we need residents' concerns, solutions, efforts to really be at the center of that work. The Pawtucket Central Falls Health Equity Zone focuses on 4 priorities. So policy, substance abuse misuse, resident engagement, and youth engagement. Because we're talking about managing diabetes and chronic disease, I'm gonna focus most of my comments around some work that we've done specifically with diabetes. So we have been a partner with Progreso Latino for a long time in their programs and efforts to address diabetes, and as they serve as a community clinical linkage. So I want to talk a little bit about our recent work with the Health Equity Challenge. The Department of Health put together a health equity challenge, and we were part of the Pawtucket Central Falls team. The project was really around creating interventions for folks with diabetes, but then also building stronger connections between accountable entities, medical providers, and the health equity zones. So our team included Integra Family Service of Rhode Island, Progreso Latino, the Health Equity Zone, and then LISC is the backbone, the facilitator of the Health Equity Zone. As I mentioned, we've done work with Progreso. Care New England was already part of the HES team, and Family Service of Rhode Island started a Be Safe Kit program in response to COVID, where they were able to bring cleaning supplies and food delivery to Pawtucket and Central Falls residents during COVID. So that was the makeup of our team. I want to take a step back and just talk a little bit about the context in which we started our project. So there were definite realities in terms of both diabetes and COVID when the project started. So just as a reminder, that COVID has really hit Pawtucket and Central Falls in a significant way. And we also know that the disparities that impact lots of health outcomes have been true in relation to COVID as well. So we started this project back in March, and we're really just at the beginning of some of what was happening there. In terms of diabetes, we see similar kinds of things. So 9.4% of Rhode Island's adult population knows they have diabetes, but then we can start to look at the impact on having living below the poverty line or poverty level on the chronic disease, and it's really significant. And the same is true for minorities. They experience diabetes at an earlier age, so are really managing the disease over a longer period of time. So we have the Rhode Island data, and given the demographics of Pawtucket and Central Falls, we know that these we can sort of extrapolate that the issues are facing our neighbors and residents, in addition to what we see through our partners and their program experience. So all of this was sort of in the background as we started the project. The idea was really to, again, work on an intervention that would help individuals facing diabetes. So our first step was to do a little bit of a mini needs assessment. We looked at behavioral health services and case management, food access, and then diabetes education as well. So there are a lot of different directions that we could have gone with this. We really focused in on food access. The individuals that we were working with through Progresso all mentioned, and it came up consistently, that access to healthy food was a barrier in managing diabetes. We also did a little bit of a needs assessment or an asset map and connected with the food pantries and confirmed, yeah, it's difficult to get healthy food if you're accessing food through a pantry. And then lastly, our HES had done an assessment back in the spring. And again, food access came up most significantly among our collaborative partners. It was one of the highest things they rated was access to healthy food. So we decided to focus our efforts on healthy food access for this particular project. For the pilot, we worked with the Be Safe program that was already in place. They had kits that they were delivering for folks with cleaning supplies and some shelf-stable food. So we really tried to leverage their work. We delivered 2 of these kits to a cohort of 15 folks. Many were connected with the Progresso and Care New England team, so they had that relationship and those connections as well. We did 2 deliveries to each participant, and then a week after the first delivery, recipients provided feedback on the kit. The Be Safe kits already included that shelf-stable food, masks, and cleaning supplies. But in partnership with our folks with lived experience, we made sure that the food was then tailored to a diabetic-friendly diet, included measuring cups, and then the diabetes placemats that talk about good food and then also portion control. We kind of tweaked the kits based on the connection with partners and the folks that were on our team. Through Progresso's follow-up interviews, 100% of our participants indicated that the kit had food that they liked and that it helped manage their diabetes. Many said they enjoyed the fruits and vegetables, and about a third said they were able to use all the fruits and vegetables and all the food. So we were super excited about those results and are now starting to think about how can we expand this, really connect it with the larger food systems and see how we can make the project bigger and have a wider reach and wider impact. One of the first steps we took was really connecting with the food bank, the Hunger Task Force, Farm Fresh Rhode Island, a lot of different experts in this field to see what might be our next steps. So we're working on that and seeing what is the potential for growth here. So I really focused a lot of my comments today on this one particular project, but I think it illustrates the efforts to address upstream approaches collaboratively with community healthcare, residents, and to really address the barriers and disparities in health outcomes. So I see this one project that we've really talked about today can illustrate how to chip away at and at times undo or redo systems that impact health outcomes. I think, am I turning it over to Al now, I think?
Alrighty. Close up. And share my screen.
Yes, you are. Al
Okay.
can go next.
Alrighty. Let me just pull up. All right. This is not working. Okay, give me a second, folks. All right, why is it? I'm having technical difficulties here. Let me just see here. Oh, here it is. Okay. All right, so my name is Al Whitaker, and I'm the project director for the East Providence Health Equity Zone. And I think Robin kind of gave you the foundation as to what health equity zones are all about. We are a collaborative, place-based initiative. I think the beauty of a health equity zone is that, we are able to be very inclusive, as far as decision-making is concerned. And that would be, we bring together members of the community, whether it's an organization and or residents, and other entities throughout the community to come together and really prioritize as to what are some of the needs within the community and what are some of the social determinants that are, serve as barriers for people, for example, accessing quality health or, accessing health in general. So we also, as part of our Diabetes Health Equity Challenge, identified food as a food insecurity as a priority. But before I get into that, I just want to give a brief overview of, what is EBCAP. So the East Bay Community Action Program is actually our backbone agency. And so they kind of oversee our fiscal, the fiscal responsibilities of the HES, and really provide support and guidance in our initiative. And so, we're from East Providence is one location. Actually, the East Bay CAP covers from Newport all the way up to, so Newport, all on the upper and lower bay of Rhode Island. Okay, so we do have a health team, our Diabetes Health Equity Challenge team, which consists of myself and then Carla, who is actually the manager of integrated health. And she is, the representative of our community health team. And then we also had representation from the health center. So we had two nurse care managers. There's Maddie Marr and Caroline is the one in the picture. But we also, as part of this challenge, had a person with lived experience. So initially we had one, and just due to some other stress or other issues, she had to step away from it. But then we were able to, find another individual in Jamie. And Jamie has actually been, I cannot stress the importance of having someone with lived experience. Many times when we're meeting, we kind of look at the bigger picture and, lose sight of what someone who is living with diabetes and there is a lack of access to healthy foods. What are some of the issues that they're going through? So she really brings it home. And, we're glad to have her on board. So who do we serve? So East Bay Community Action Program, they serve, so as I said earlier, it's all the upper and lower bay, but if you break that down, is Barrington, Warren, Little Compton, Bristol, Portsmouth, Middletown, Newport and Jamestown, as well as East Providence. So to get into the nitty gritty, so we looked at basically what are some of the existing inequities in the East Bay. And this was done through conversations, not only with the patient population, but also we got a lot of this information from our person with lived experience. So when we began to identify that, we looked at medical and non-medical transportation was really a big issue. So people were having a lot of difficulty in actually getting to the services needed at the health centers because of lack of transportation. And then access to nutritious foods. Housing was another issue, and then mental health with the current state of the country and the world. So, I just want everyone to be mindful that this was in, this pilot actually began in a COVID environment. So a lot of the focus at the time was on COVID and how do we respond to that. So as we began to look at that, we realized, or one of the things that stuck out was access to nutritious foods. So EBCAP does have a food pantry that has been very effective. However, the issue with that was that there weren't, they were providing some of the basic staples. However, there was a lack in fresh produce. And so what we did was we partnered with the food pantry to bring to, we identified actually 10 people in a residence in East Providence living with diabetes. Some did access the food pantry, others did not. But we identified those 10 and were able to provide them with some fresh fruits and vegetables in addition to what they were receiving from the pantry. So we did come up with a plan of action, if you will. So in our first step, what we did was, we kind of did some basic needs assessment, gathered some information, really looked at, where was the access? Were people accessing fresh fruits and vegetables on a daily basis? And if not, what were some of the barriers? We reached out to existing food pantries to find out what they were actually doing, or how were they responding to the lack of fresh fruits or fresh produce. And then we did some research and then outlined some possible solutions. So really looked at some best practices throughout the country to see if we could actually, mirror or maybe use that as a model. And then in the second stage, we actually developed a strategy for intervention. So how are we going to respond to these folk? And so we had conversations with patients who were living with diabetes, and basically a needs assessment, once again, asking where did they feel there were gaps? Was access to healthy foods, was it there in the community? Interesting, we found that the response was, yes, there is healthy foods, fresh fruits, produce are accessible. However, the cost is a deterrent. And then we actually did some recruitment. EBCAP is a very large agency. And so we reached out to some of our patients in the behavioral health department, as well as community members and community health team patients, and those patients that were actually utilizing the services at the health center. And then further, we actually did some outreach to Exeter Farm to see if, in fact, we would be able, and I think that, when I talk a little bit about sustainability, I'll probably talk more about this, but with Exeter, to see if we could work on a collaboration in which they would be able to provide us with fresh produce on a regular basis, monthly or whatever, so that we could provide, have this fresh produce accessible to our clients. And then in the evaluation piece, we actually gathered post-interview intervention data, similar to what was done in Pawtucket and Central Falls, was that we really wanted to ask them, what did they think of the quality of the food? Were there issues with it? Did they like what they got in their packet? And then based on that, we would be able to tweak that. One thing that did come up, and this was actually from our person with lived experience, was she loved the food. However, in addition to diabetes, she's also suffering from arthritis. So, staples such as potatoes or squash that were, delivered or provided in whole form were very difficult for her to cut up because of her arthritis. So the recommendation was, or the suggestion was, could we, identify an entity that would be able to provide us with cut up, something that's a little more user-friendly, squash or potatoes. So what was some of the evidence of our success? So success, and this, it was actually 10 people received bags of diabetic, diet-friendly foods. I will say that how we were able to identify what would be diabetic friendly food is we actually worked with our nutritionist who is actually responsible for WIC in EBCAP, and she provided us with a list of foods that would be suitable for someone living with diabetes. And then our initial interviews were done, and we also were able to complete our exit interviews, if you will. And then, I think we really wanted to look at, well, what were some of the barriers for this? I'll just preface by saying this was a really something that happened very quickly with a very short turnaround time. And so in the midst of COVID. So, some of the responses from the staff that were working on this program was time and conflicting obligations of the team members. There was it was almost this strain of having to do this. And, we wanted to be as efficient as possible. So, time and conflicting obligations came up. And this is something that when we look at sustainability, we would like to address further to see if there is a way in which we can alleviate some of that, that conflicting obligations and, maybe hire someone who could take on, more of the administration of the project. However, there is also, and I can't stress this enough, is we also learned that there is significant value in having a person with lived experience actively engaged, I should say, in the process, in the discussion, providing feedback, really helping us stay focused. And not only that is, this particular person with lived experience has even gone out to, Best Buy and different stores or companies, actually, soliciting, is a possibility we could get refrigeration, and what would that look like? Would they be willing to make those donations? Actually going to the supermarkets and seeing if in fact, because there's something called rescue foods. So if we might be able to have access to that, so we could provide that, to the people in the food pantry. And then we also realize that everyone has a different experience that brings to the table. But I think that this is so indicative of what a health equity zone is all about. So, following that model, we're able to actually, we all come from different backgrounds, but I think that the passion there is that, we want to see this project through, and we do believe in providing the best access we can for our community to actually reach the most optimal services. So I think one of the challenges was, how do we identify so many patients that fell into that particular category or met the criteria, which was that they had to be living with diabetes. We preferred that they utilize the food pantry and be engaged in some of our services. And so moving forward, we would like to extend that, a greater reach to other members of the community. And then looking in terms of sustainability, how do we make this sustainable? How do we go past, this ended in September. However, we did get an extension. So now we're looking at how would this look like by the end of December. And that is that we want to increase the number of people that we're able to serve. So to take that from 10 to 20. We also want to be able, to a major conversation that has come up, and this is probably, not only for from now till December 30th, but even after, is how do we expand our person with lived experience? And so there has been a lot of conversation among the team as to providing or trying to build a community advisory, if you will, or I would say community advisory that would consist of people with lived experience who would be able collectively to inform us on the actions we take and the things that we're about to do. We are looking, as I said, to scale this to probably for 2021, 50 people. We are looking to be able to have some kind of refrigeration so that, some of this food that has a very short shelf life, at least with the refrigerator, it could last a little longer. And also bringing on more staff and more partners. One of the things, and I think it was a challenge, and we all agreed that, we could have had the opportunity to do more outreach to some of the other community organizations in East Providence. And so we definitely want to bring on board the East Providence Senior Center, because they also provide foods to those that are socially isolated. So how can we work together? So we're thinking of, what that might look like. And then actually for those that can't get to the food pantry, would we be able to underwrite a driver who would be able to make those deliveries to those that are socially isolated or in quarantine, or who are seniors and just don't get out. So, this is a work in progress. It's been a great learning experience. I would say one of the benefits for me is that we're able to incorporate, some of the tenets of the HES in this this pilot so that, the whole concept of collaboration and working together is really front and center. So if you have any questions, I will take them.
Yes, one of the questions is, do you have any bilingual workers that you're able, offering different services in different languages?
Yes, we do. So we actually have, we have one particular person who actually speaks 5 languages. But for East Providence, we have a large Cape Verdean Portuguese speaking population. And so we do provide this in Portuguese and Cape Verdean Creole, as well as Spanish. There are pockets now of Russian immigrants that, we're also looking at as well. So, this is a work in progress, but, that you bring that up, that is something that, we're beginning to look at, well, who's out there? And, are we being culturally sensitive or culturally appropriate? And that's not only with, what we distribute and if we're being able to communicate with that particular. So as we begin to look at the food stuff, is it culturally relevant? Is it culturally appropriate? So, another idea that has come up is that we would actually start to look at healthy recipes that are culturally appropriate. So, kind of going through that and really working with a nutritionist who would be able to help, and or CETO, a certified diabetes outreach educator, to help us to put that together and make sure that, it's diabetic friendly or diabetes friendly.
And you mentioned, since the door-to-door services is currently a work in progress, is there a way that you're doing contactless to be able to get the food, that you're dispersing the food in a way that, folks, pandemic and everything?
Well, I'll share with you this. So, and this is a separate funding, but we try to incorporate two. So we have right now for the CARES Act funding. So this is money that is real in response to COVID. And we have hired community outreach specialists who are actually going out into the community. They're providing PPE, but in addition to that, they're also providing education. So it might be COVID-related education, but we're also doing a little assessment. So do you utilize the food pantry? Are you living with diabetes and those things? So that's going to help us when we go to 2021, that we would have a larger group or a larger pool of residents in which to work with. So yeah, we're just trying to be as creative and as strategic as possible and try to leverage every opportunity we have. So yeah.
Perfect. Thank you so much, Mr. Whitaker. I believe next we're going to have Ms. Allegra Scarf with y'all.
Sure, and thank you so much for having me. I'm just going to take a second to share my screen. Can we see?
Yeah.
This? Okay, and now you can see the from current slide.
Yeah, can you blow that up a little bit, Allegra?
I can't actually.
Okay.
I really apologize. Don't know how to make it any bigger. But yeah, so my name's Allegra. I'm the Health Equity and Evaluation Manager at One Neighborhood Builders. And One Neighborhood Builders is the backbone for the Central Providence HES. And so we actually have been working in one form or another on addressing chronic disease in our area for about 5 years now. It's changed a lot over that time, and I'll get into that a little bit. But as Al and Robin mentioned, the health equity zones are based on a lot of resident engagement and feedback. And so when we were originally the Onlyville Health Equity Zone, we did dozens of community events, hours of interviews, some intercept, some longer form, a lot of community meetings. And from there, we came up with action items to address in the neighborhood. And a lot of those were around food access and access to things that we hope will prevent chronic disease, such as affordable places to work out, safe housing, stuff like that. And so over the past 5 years, before this year and before COVID hit, we were able to bring around 4,000 residents free and fresh produce at our food pantry. We had a lot of free youth summer camps. We worked with the Steelyard, which is an arts organization in our area, to actually design some community fitness equipment and install it in the park so people have a free place to exercise when they're walking around. And actually Al brought this up as well, and I'm glad he did. Through this, we realized, a lot of this was working. People were able to access more produce if they were going to the pantry. People were able to exercise more now that it was more affordable. But we were missing people. And so every year, as I noted, we do an assessment, and we learned at the last year of this first round of Health Equity Zone funding that we saw a 30% increase in residents who believed they had access to healthy food, which was amazing. More park use. And we also saw a 5% decrease in residents saying that they were diagnosed with chronic disease. But there were people that we were missing, and we weren't quite sure how to get them is the first issue. And then the second issue that we were having is that finance was still the biggest barrier. And so as a Health Equity Zone, we were looking for a way to both address economic opportunity, how we could help people in our neighborhood continue to grow in terms of their career and be able to really support themselves so they weren't relying on these unsustainable sources such as bringing, fresh produce to the pantry. And also, how we could reach some of those unreachable populations. And that's where the Community Health Work Network was born. Can everybody still hear me? Because I just lost.
Yes.
Okay, I'm sorry. Okay, so the Community Health Network is now, I think, 3 years strong, and it is a group of 12 different community health workers working both at One Neighborhood, which is our backbone organization, and also clinical and community partners throughout our Health Equity Zone. And they are working to, as best they can, reach those hard to reach populations while also themselves embracing their ability to be kind of socially mobile, economically mobile, and continue to grow in that regard. And so these community health workers, for the most part, are from the neighborhoods that we serve. They are representative of the people that they're working with, which helps us build trust. And they also are highly skilled. And so one thing that I think is really important to mention about our CHWs is that the term community health worker is often discussed, and it's also often used to describe people that are doing community outreach or people that they hire to do resident engagement that aren't necessarily trained. But at the core for our community health worker cohort is that they have 144 hours of training. They become certified community health workers on the job. All of their training is paid. And then they also continue on to do different trainings as well. And so 3 of our community health workers now have this training in cardiovascular disease and diabetes management on top of the 144 hours of training that they get. And we're hoping that as time goes on, we'll have more that have this training. So what do these community health workers do to address chronic disease? We have built it in now that anytime we enroll a resident, we are asking about their diagnosis. Because we're not specifically connected to a clinical partner, we can't get this medical information, and it is all self-report, which has its limitations. But people have been, for the most part, we think, pretty upfront. So we work on this system called Unite Us, and we ask everyone that we work with, has I can't speak today, anyone told you that you have diabetes? Has anyone told you that you have high blood pressure? Or has anyone told you that you have high cholesterol? If anyone screens positive for this, which this example, they did not, but we ask about their confidence in managing this disease. And if they are not confident or somewhat confident, we ask what it is they would need to do to help manage this disease. And so we have options, and of course it depends on whether or not someone screens positive, but also what they identify as being those issues to manage their chronic disease. If it's a matter of education, then right now our go-to is referring them to Ripen, which is you guys, I didn't realize. But that is the plan. And so Ripon obviously now has the community health network that has a lot of different educational opportunities for residents that have diabetes or that want to prevent diabetes, all that kind of stuff. And so we can refer directly to Ripon in the system, and we can note that they have a chronic disease, and that's one avenue. The alternative is that our community health workers can work with people directly on other issues. So perhaps it's that they don't know where to get produce that's fresh and affordable, or alternatively, maybe it's they have diabetes and they can't afford their insulin and they need cash assistance, which we can also provide. So it really varies, obviously, dependent on what that issue is. And again, this is for people that have already been diagnosed. This is from 1 week, as you can see, from October 20th through the 26th. And we had 12 screenings, I think, maybe it's 11. 12 screenings that were done that week. And of those 12, we had 5 people who said that they did have a chronic disease. And we had 2 people that weren't confident with dealing with it. And we had another 2 people who were somewhat confident. So it's really those people that our community health workers will focus on referring and or working with one-on-one. What we're seeing now, and to my last slide, it'll make more sense, is that because our focus has been on COVID and getting direct referrals from the Department of Health for people who are COVID positive and other stuff like that, it has been hard to work with people on chronic disease at this moment because they have other concerns that are taking higher priority. So for us, we're getting a lot of residents who need cash assistance more immediately. They need help with groceries because they're in quarantine or isolation and they can't get in themselves and stuff like that. So we have this available, but the good thing is that once we work with them on these types of emergency services, they're in our system and they're clients until they decide that they don't want to be anymore. So we continue to reach out to them after we do this kind of quarantine and isolation support. And we hope that even if they come into us that way, that eventually we'll be able to work with them on chronic disease stuff as well. So I will stop sharing my screen. I hope that was relatively clear. And if you have any questions, I am here.
Yes. So in order to get resources, do you have to live in a specific city or can any Rhode Islander get assistance?
I should have mentioned that. Yeah, I apologize. So we are the Central Providence heads. We work specifically with people right now that are in 02909, 02908, and 02904 in Providence. We do, obviously, there's a lot of different health equity zones. And if we have someone that's having an issue that's in 02907 or 02905, whatever, we can refer them out to different HESs. So it should never be a barrier to calling us if someone lives in a different zip code.
Perfect. I just want to thank each panel member for being here today. Thank you so much for your time. We really appreciate it. Folks, this is the last of our Friday Healthy Conversation. We hope you have enjoyed them. This has been presented as part of Road to Wellness 2020, leading up to Rhode Island World Diabetes Day, coming up on Saturday, November 14th, from 9 a.m. to 5 p.m. This is the first ever virtual World Diabetes Day, and you can sign up to join us at www.riwdd.org. I'm not sure if any of the panel have any final words before we go. Doesn't seem like it. So we hope that, oh yes, Robin.
No, so much for having us.
Oh, of course.